Good morning, thanks for having me so much today, and thanks to Reverse Rett and Yvonne and Chris, who have always helped me to get out there a little bit more and promote myself. So hopefully I'm going to bring some bits together from some of the scientific background and put it into what actually happens at home. My experience is as a respiratory physiotherapist that's kind of developed into being an accidental learning disability physiotherapist and then accidentally knowing a little bit about Rett syndrome, but obviously you're all the experts in that. So my job's a little bit different. I'm not going to teach you how to be a respiratory physio. I'm going to share my 14 years experience alongside one incredible lady with Rett syndrome and what I've learned from her and how that can impact on care in the future. So we might not have a lot of time, but if you do have your phones, can you scan the QR code or go to slido.com and put in the number, and there's a little question there about what worries you most about your loved one's breathing or their chest, and let's see if this works. And as you answer, if this works, it might pop up. Oh, people are typing, and hopefully we get some words up. So this is the first thing that I ask families of patients, what's concerning you the most, because it's about listening to people and hearing what families and loved ones say. Breath holding is definitely a concern. We'll talk a little bit about that. Winter infections, pneumonia, hyperventilation. Absolutely going to cover most of that today. Brilliant, thank you. So it's just super important to get a bit of an idea of what's your concern. So I've dedicated this session to Claire. This is Claire, and she's taught me more about respiratory physio than I ever thought I could know, and not in a traditional sense. Respiratory physio is pretty traditionally in the acute setting, and I've set up more in the community because there was such a big gap and need. So this has been covered before by Professor Sharma, and a lot of the other amazing speakers, so this is quite intimidating to follow up. But respiratory health isn't just about the lungs, it's the whole thing. It's really where, the brain centre, where the genetics, where everything begins. The breathing pattern, which we've touched on, hyperventilation and altered breathing pattern is so important and so relevant in Rett syndrome. The importance of sleep, swallowing, movement, posture, and then lungs. So it's not just one thing that we talk about. The thing that I hear the most, and this is Claire not having physio, she doesn't smile like that with physio. I mean, we try. But the things that I hear from people, particularly when things are starting to turn and we don't quite know what's going on, is it an infection, is it a chest infection, is it a UTI, is it just a bit of wind, is these sorts of lines. So I think the main thing to remember is trust your instincts. You know your loved one better than anyone else. I'm the same with my kids, taking them to the GP. I know them, and I do turn up with quite extensive notes to the GP, so I'm probably not their favourite person. But I think it's trusting your instincts and knowing what something's not right and teaching carers what the subtle signs are, because that's how you build that relationship with them. And it's very hard as a therapist to go out and meet somebody once and make a decision on their long-term care for that. So Claire is in her 40s. She is just amazing. All my kids have met Claire, haven't they? Yvonne had a panic when I had my twins. I was going off on maternity for a long time, but it was fine. So everything about Rett syndrome has been shaped by Claire. But this isn't just her story today. This is relevant to every family in this room, and how wonderful she is and how Yvonne and Chris advocate for her to keep her healthy and well. So I first met her about 14 years ago. She'd had a couple of admissions with pneumonia, and Chris Googled and found me, and I happened to live up the road, which is a bit random. So the stars aligned, should they say. So she's taught me so much. These are some of the quotes, I may have amended them to fit them on the slide, that Yvonne and Chris have given me that I think are really powerful, that it's about prevention, doing everything possible Claire having a peg was in an acute setting. She'd had a really nasty chest infection, and it wasn't a very nice way to make the decision. Ideally, these sorts of conversations and decisions should be made before it's that emergency scenario where your stress levels are up here, you're in crazy high gear. But like I said, trusting your instincts, and certainly from a respiratory physio point of view, I don't profess to understand the condition. I can't possibly understand every condition that I'm treating in that much detail. I'm looking at that individual in front of me and what are the problems and what are the risks. And certainly one of the things that has benefited myself and Claire, and now my team going out to see her as well, and me trusting them to see her and do a good job, is knowing her really, really well over quite a long period of time. So what can you do at home? Hopefully this works. So I think the first thing, we're going to talk about cough assist, and I can talk about LVR bag and the vest and suction, but I think the first thing is movement. And that is the fundamental basis of physiotherapy, is what's normal function and how can we try and maintain that as much as possible. So movement is key. She's dancing, she's not having physio. Okay. And this makes me really happy because she's moving. She's got some independent movement. She's smiling. She's going to take some deep breaths because she's smiling and laughing. She's rocking. So she's going to be doing more deep breaths. So I'm thinking, oh, brilliant. This is physiologically. She's taking deeper breaths. She's going to clear her chest a bit more and get that ventilation. We talked about ventilation perfusion, the VQ matching, how you're really trying to balance that so that her rest of her body gets the oxygenation that it needs. But also things like that circulation, getting the blood flowing, getting the heart working. Super important is body shape. So Claire's got a significant scoliosis. You can't see it that well here, or you can see a bit of a lean to the left. And she's got a spinal rod. That has a massive impact on her chest wall, and that is probably one of the main issues. Is she's so rigid in her chest wall, and she's got the spinal rod that things can't move. So her lungs per se, and she's had a CT, are in good condition. Considering she's had multiple pneumonias, it's pretty impressive. So her lungs are in good condition, but it's not actually the lungs that are the problem. It's the rib cage around it. The muscles get adapted. So if you're not expanding your bases regularly, your diaphragm can actually shorten and change. And then you can't re-stretch that. It's basically like a contracture. The muscles around her neck, because one shoulder's higher, the accessory muscles around her neck can't stretch and relax as much, so it becomes harder for her to breathe more efficiently when she is breathless. So that chest wall shape and the general posture is so important. And one thing that I just wanted to say actually is I'm an adult physiotherapist, so I don't know what I'm doing with children. So don't ask me paediatric questions. Their chests are completely different. However, I think a lot of this you can prevent some of the postural deformities that you see by whilst their bodies are developing, whilst they're going through adolescence and puberty. What can we do to prevent body shape changes? Because actually when you look at certainly adults with learning disabilities as a whole, and you look at Rett girls and boys, they're quite predictable body shape changes. I think what's the impact that gravity is having on their body shape? What can we do to prevent that? And movement is key, posture's key. And if somebody can't move, what can we be doing to support that? So any movement, any exercise is beneficial, is what I'm saying. It doesn't matter what it is, at what stage. We've got things like standing frames, walking frames, on the floor mats, just some sort of freedom of movement to allow the muscles to stretch and get as much ventilation as possible. When I did do some paediatric physio back in the day, mostly with CF, laughing and crying counts, because it turns out you clear quite a lot of secretions when you do that. They mostly cried with me. I think that might be why I'm not a peds physio. So I wanted to just talk a little bit about posture. So we've touched on that a tiny bit. So I just found a random picture on the internet and popped it into ChatGPT, and it gave me a slide. But you can see here that, one, would you be comfortable sat like that all day? to have a think about what's going on in the lungs there. So you can see that the chest wall is meant to be symmetrical, but actually things are quite wonky, and her right base would not be ventilating very well. So that touches on what Professor Sharma was saying. So the chest wall is distorted and compressed, so she's not able to ventilate very well down in that right side. The left side of the lungs are quite stretched. It affects how efficient the muscles can be around the rib cage. It touches on poor airway clearance, but actually if you're blocked on one side, you can't take a big deep breath, and you're not going to be able to cough as well, which we'll touch on in a bit. And then it's going to be quite hard work as well. Fatigue's quite important in terms of, especially if your cough's insufficient, then fatigue is not going to help make that any better. So posture's super important, how we can get people, again, movement, but if someone's quite immobile, what can we do to keep them in one position? There's quite a lot of research in physiotherapy about, one posture is perfect. There isn't such a thing as perfect posture. I mean, I'm not exactly an advocate for it, but you can't, if you stayed in one position all day, every day, you would ache and it would hurt. We're not designed for that. We're designed to move. So the more movement, the better. If you're in one position and you get uncomfortable, you move and change. Some people with Rett syndrome aren't able to do that, so we need to facilitate that. So good posture is super key to good quality lung health. Thinking about symmetry. I mean, I love a bit of symmetry. I think it makes me a bit OCD being a physio. But well supported, feet being well supported is really important, because actually from a neurological point of view, if the bases of your feet have lots of nerve endings, if they're well supported, it's going to help for you to work up through your pelvis and have a much better midline posture, and then you're working a lot less. If you're thinking about when you're sat on the edge of a bed and your feet aren't down, do you feel stable? You're on an unstable surface, you're not very stable, so get those feet down. And feet being strapped in to wheelchairs might look unpleasant and look restrictive, and don't get me wrong, it is restrictive, but actually really thinking about what are we trying to do here, what are we trying to achieve, and level pelvis. If you can get pelvis level, then happy days. As well as head being well supported, so that then the rib cage can move well. So that's just a bit of an example. Quite happy. I think the slides are getting shared, so more than happy to send these out. So use gravity to be your friend. Gravity produces quite predictable changes to body shape if you're in the same positions day in, day out. And you can see it with little old ladies with Dowager's hump. Gravity's had a negative impact on them. So using gravity, thinking about positions, thinking about that 24-hour postural care, but that's I could do a whole nother talk on that. Lesson number 3 is oral hygiene. You guys are probably great at this, but actually the stuff that I see in the community and in care homes and nursing homes, not just in Rett syndrome, is pretty appalling, especially with people that have a PEG or any sort of gastrostomy tube. It sometimes gets forgotten about, but you still produce saliva in your mouth. Your mouth's pretty dirty, even if you keep it immaculate. And we've also already talked about silent aspiration, and that can be for somebody who's nil by mouth, but actually they're aspirating on the bacteria and the saliva in their mouths. So really, as much as this isn't chest physio, I've definitely had to step up into this, and there's a document that NICE have published for oral hygiene in care homes, and I've kind of just extrapolated from it, and I get the care providers to do it's one page, do a quick scoring system of oral hygiene, and it helps us to get speech and language referral, get some, you can get toothbrush heads to go on the end of yankers, thinking about non-foaming toothpaste, because if somebody has got an impaired swallow, we don't want to be shoving loads of liquid into their mouths. So just good oral hygiene can make such a difference. And then secretion. So this is the respiratory physio's dream. We talk about sputum all day long. So Professor Sharma's touched on this, just wanted to go into a little bit more detail. I will see very different people. I have some people come into clinic who've got things like bronchiectasis or have been in hospital with a pneumonia and no other condition. And we will always try to mobilise secretions. We all produce mucus. We all cough every day. Most of us will swallow it. So it's actually really normal to have a little bit of a cough every day. And if you don't, that's probably more concerning from my point of view. But persistent cough and persistent ineffective cough is a concern. So from a respiratory physio point of view, we're looking at Are there retained secretions? Can we shift them? Are there more secretions than normal? What's the quality of them? We want to know colour, consistency, amount. Is it being cleared? Are there frequent chest infections? Have there been lots of medication involved? Are they on things like hyoscine, things like that dry up mucus and things? Is that actually causing a problem? So when we're talking about mobilising secretions, one of the basic models for chest physio is something called ACBT. It's the active cycle of breathing technique. It's really boring, but I don't know why they called it that. It's basically you do some deep breaths and you huff and then you cough. It's actually done really badly in even my senior physios that were teaching me back in the day. I was slightly horrified. So I have a YouTube video on how to do that if you want to watch that. But it's basically you're taking deep breaths because what you want to do is get the air behind the secretions. You want to, if you're just doing some quick, fast breaths and there's secretions low down in your lungs, you're not going to unstick what's down there. So we think about the airways as an upside down tree. We want to get the air behind the secretions. So taking a really long, slow, silent in-breath and really trying to fill the bottom of your lungs really makes a difference. So somebody that could follow those instructions will be able to do that, and actually most people find that really hard. So have a go at doing a massive, long, slow, silent inhale through your nose and see how long you can breathe in for and really fill. And then hold it and then let it out. So you've really stretched out your bases. You've got, some of you might find you clear a little bit. Have a little. So getting somebody that's not able to follow commands like that is tricky, and that's where the cough assist can come in handy, because we can deliver a longer, slower, deep breath and we can put a bit of pressure behind it, which then can help open any tiny collapsed airways as well. But that's where things like movement and laughing and dancing and things like that can do that for you, and it's less boring. So we want to unstick everything and then we need to move it up. So I don't know if this is anatomically correct, but I was once told that if when they used to open up a cadaver, they would put the lungs out on the floor and it was the size of a tennis court. That's probably not dissimilar to the size of this room. And so if you think about sputum right down here on my right base, has got to travel all the way across to get out. So suction is only going to clear what's in the main airway, but actually you want to unstick and mobilise everything to get it high so that when your loved one does cough, they actually clear that really satisfying amount that was on the video earlier, because that made me smile. I don't know if anyone else smiles, because I'm like, oh, it's beautiful, it's lovely. Oh, look at the colour of that. So we don't want to be getting people coughing and getting fatigued and working really hard if we've not mobilised everything and moved everything up. And you want to try and reverse the reversible. So if somebody's got really tight chest, maybe got asthma, maybe it's hay fever, or there's a wheeze there because they've got loads of sputum, we want to reverse that. So that's where bronchodilators come in, and that might be a nebulizer, it might be an inhaler. Again, I could go on all day about inhaled therapy and which one's my preference and how to do it, but there's options out there for people that can't perhaps take a normal inhaler, and we need to be thinking about drug dose a little bit as well, because nebulizers can be quite a high dose and there can be side effects to that. So there's ways and means. Yvonne and Chris know I've been banging on about that for a while. So you want to reverse the reversible, so bronchodilate and hydrate. If you're dehydrated, your sputum is going to be like glue and nothing's going to shift it. So this is all a waste of time. So hydration is really key, and that's what I remember the most about Claire before she had her PEG, was she had this chest infection and we were desperately trying to keep her at home and shift it, but then she was dehydrated because she was only able to take fluids orally, and that it was this really difficult scenario that ended up in her having a PEG, but actually she's done incredible with it. And from a therapy point of view, it just means I know she's well hydrated now, and I know that her secretions are really loose. Lesson number 5, sleep. There's been a touch on abnormal sleep patterns, and I would always encourage you, if you're noticing any sleep issues, is to refer to respiratory, and there's often sleep specialists. I don't particularly work in secondary care anymore, and I work for myself, quite independent of the NHS now, so I'm not quite sure exactly what's out there, but just making sure that trusting those instincts and escalating it. The main thing I wanted to say about sleep was just the fatigue. Again, with Claire, if she is working really hard to breathe faster and to cough because there's so many secretions, you quite quickly notice her cough deteriorates from being just about effective to kind of being totally rubbish. And then she needs a rest. So it's a real balance between exercise, physio and rest to then allow her to recover, allow her to have the energy to have a cough. So that was kind of my main thing that I wanted to cover there. Completely gone off track on my notes. Okay, so talking a little bit about chest physio, this is Matthew. Matthew's quite naughty and a massive flirt, so if a woman turns up, he basically smiles constantly. He knows I'm videoing him, as you can see it in his eyes. So he's having percussion. I teach the carers and the day centre staff this. He's CHC funded for me to go and see him. He has another physio to deliver all his other care. He's not got Rett syndrome, he's got cerebral palsy. So you can see that she's drumming on his chest with cupped hands. I don't know if you've got the audio. It's quite a dull sound, so it might look like we're beating him up, and it has to be quite firm because you're actually trying to unstick everything. So we're doing that first phase. He's had his nebulizer, he's had his... he's peg fed as well. He's had that. We don't want to have that too close to having chest physio because we don't want to create an aspiration. So the gold standard would be an hour after any sort of feed or anything through orally or through the peg. That's really difficult when you've got a really busy day. So you have to kind of weigh that up. So people aren't often a fan of me saying that, but I'm not going to take any risks. So he's having chest physio on his chest wall. He actually really loves the interaction, so we're not looking to put the vest in for him, but he's got all his carers trained up, and it actually reduces his tone as well. He's got really, really high tone, got spasticity, you can see with his hands, and actually really lowers that tone as well, and he clears really well. It's not for everybody. I would be very cautious just starting percussion with your loved ones. Again, I'm not a peds physio, but there are things that it can cause problems. I did have one lady with cerebral palsy who was in her 20s who had a rib fracture, and we think it's from the percussion. We've got no proof. It went through safeguarding. It's not very nice that we found that on her. It was a healed fracture on her x-ray, but it just brings to light that a lot of our, especially females, are more likely to have osteoporosis if they've never really weight bared, perhaps nutrition's not been there, so it brings everything together. So it is something that ideally is prescribed by a respiratory physio, but I know that there's not many of us about, but it can be helpful. So I've put the contraindications on just to safety net it, but it can be quite helpful to do. And then you've got the vibrations. So you can see it's Matthew again. He's having his chest shaked. So we're trying to move the phlegm up now. So when he exhales, we're shaking his chest from large oscillations into small oscillations to try and help move the phlegm higher, so then he can cough and clear, and we'll suction that out. Most carers find this really hard. She's the best, this lady. That's why I videoed her doing it. She does a really nice technique. He's got lovely springy ribs. Sorry, I get excited for that. Claire does not have lovely springy ribs. Claire's ribs are rock solid, so you're like, oh, don't want to go too hard, which is why she's got the vest. So this can be really effective if it's done well, but in isolation it's not enough. So it's about that bigger picture with positioning, movement, patterns and any equipment. This tends to be where I'll start because it's free in nothing's free, but it's free in lots of ways. Because you've already got caregivers there that I can teach, so it's a quick win that I can make a difference to somebody, and then we can start looking at funding for equipment and things, which is not a quick win. So not everybody needs equipment, but I know that I wanted to touch on this. So Claire's, we've tried everything, haven't we? So I'm going to talk a little bit in order of what we chose to do with Claire, because we didn't jump straight into the cough assist. That's actually just quite a recent addition. So when I met her, she was having these infections and she was producing more mucus than normal, and she was able to cough it into the back of her throat, not on command, but she was using a standing frame. She was having regular stretches, massage, those sorts of things. So we put suction in first because it was like, actually, which phase do we need to clear? We need to get it out of her mouth so it's not dripping back down into her airways. So we got suction in and we got oral hygiene in, which is just so much better than it used to be. She used to have she'd cough it into the back of her throat and then it used to just coat her mouth. And it was just like glue, wasn't it? And then she would have a really sore mouth. And then there was little cuts and things where maybe someone was trying to scrape the thick sputum with the yanker, which was just an absolute no-no. And actually the care staff now have totally nailed it. So she has a full regime. That just means that her mouth is just really, really clean. So she's unlikely to aspirate. It's not impossible. And oral suction, someone's got one, I've seen one, I've heard it, that sound, I know that sound now. Actually, I was travelling back from training some physios in London the other week and the taxi driver was like, "What's that noise?" I was like, "I think that's your car." It's actually the suction machine was going off in my bag. It's probably good that it wasn't on the train. Oh, let's just get this. So I've got a little video of suction with Claire, but this is the unit that I prefer to use, the LSU unit. I'm not affiliated with any companies or anything. It's just what I found caregivers find really easy to use and what I've got one. So it's basically just a canister. It's just a hoover. So it will just hoover out any secretions. And in the community, we only really want to be suctioning to the back of the tongue. So if somebody can't bring it up to the back of the tongue, then there's other things we need to think about first. There are risks, as with adding anything in. We're putting something into someone's mouth that could potentially be quite traumatic. You can actually cause deoxygenation if you're not careful. Obviously, as soon as something enters the mouth, there's going to be some chomping down on it. You don't want anything breaking and choking on it. So there's all these things to consider. I'm pretty robust at risk assessments these days. It should be trained. And historically, when we put this in for Claire about 13 years ago, it used to be the party line was that the district nurses did this, but I don't know if anyone in the room knows a district nurse that will do suction. So there's been lots of pushing back and trying to figure out who takes responsibility for this. The way that we've discovered what can work for us, knocking on lots of doors, is equipment stores provided the machine, although they're stopping that now, it's funded, CHC funded for Claire, so they provide the machine. I then have to put a quote together of all the consumables, and then our local neighbourhood team provide the consumables. It does help that I worked for them, so I know the admin, so she'll do me a favour. So it seems to be who you know rather than like there's a particular process. But there's things like the tubing, the filters and things like that don't come with the machine repeatedly. You've got enough for like a month maybe. And keeping all of that clean is really important. So it's all quite basic and quite logistic is almost the more important part of things than the actual suction itself is quite easy. So I'm going to try and find a bit where I actually suction Claire. So I did this training video just before we all got shut down in COVID. So I'm just going to show you Claire being suctioned. And that is my favourite noise. And she just pockets it, just at the back, particularly on the left where she leans, she just pockets it at the back of the tongue. So I'm trying not to touch anything, trying not to touch her mouth or anything when I go in. I'm using the lowest pressure I can, so I'm not causing any trauma. And it's quite effective. And actually, to be fair, she does smile afterwards sometimes because I think she feels that there's some relief from it. And I monitor her oxygen before and after and keep an eye on her and things as well. And this is the vest. So the vest is instead of percussion and vibs. So it's going to shake her lungs. And what's really nice about this, from my perspective, is I was training carer after carer after carer, and it is really boring. But it's also really, really time consuming, and it was quite expensive for Claire to have this, bearing in mind I'm independent and I do bill by the hour. So I've got 3 kids to feed. So the vest has worked really well. It's an initial cost, 5 or 6 grand, it's not cheap, and it's quite bulky. I don't think they've done like a new small version. She's got the wrap, like the blue one, on the side of the screen because of her scoliosis. We wouldn't have got a vest on her. So the wrap just means it goes all the way around, but it can actually impact the whole of the lungs. It's not just where it is. And you can see that she loves it. We call it the giggle vest, and she really loves it. So it's a lovely sensory experience as well. It's really nice to do something that is like improving someone's quality of life, but they actually enjoy it. So I don't need to be there. She has 10 minutes twice a day. We set the pressures with the rep as well, just to really try and get what was right, what she could tolerate, what would give us the best outcomes. We use it prophylactically. It's often hard to get it commissioned unless they've had hospital admissions with their chest. Tends to be the guidelines. She had, but I don't necessarily agree that we should be waiting for these admissions. It's cheaper than spending a couple of nights in hospital. And it means that the caregivers can just get trained up and they just pop it on, press play, and it just delivers the care. And the oscillations that it delivers are at particular hertz that really help to thin the mucus, which if different carers are delivering percussion and vibs, everyone's going to be doing it slightly differently. It's never going to be exactly the same. So that's quite nice. We've got a level of consistency with her care. It's not suitable for everybody again. There's always risks and benefits, and that's where, again, a respiratory physio should be helping with that decision. So she has that twice a day. So we started putting that in place when basically I just couldn't keep up with the training needs of the carers, because you get a big carer turnover at that point, although things are a bit better now. And we thought, actually, we need to do something about this, because I can't keep everybody trained. And then we have an instance over a weekend where maybe there was people on, or the person on shift that was meant to be trained was off sick or something like that. So we needed a bit more stability in her regime. And then the cough assist. ChatGPT just made up this picture, so I don't think there is one that looks like that. I did give it a picture. But as you know from Professor Sharma, cough assist can really help to clear the lungs. It does what it says on the tin. It helps with cough. Cough has 3 phases. Inspiratory phase, compression phase, and expiratory phase. So part of my job is to determine which phase of cough is impaired, and actually with Claire it's all 3, but that can really help you determine what treatment you're going to use. So we've done the unsticking with the vest. She's got her nebulizers, her airways are nice and loose, she's hydrated, and she was coughing into the back of her throat, so we were suctioning that out. We then were getting to the point as she aged that she wasn't really bringing it up to the back of her throat. We just couldn't quite shift it, and it's really frustrating when it's right there but you can't shift it and you can hear it. So we added in I don't think I've put it on here. No, we added in the lung volume recruitment bag, which Professor Sharma showed. And I chose to do that because it was like 75 quid, whereas I can't remember how much this was. This was 5 or 6 grand again? 6,000. I mean, this is not cheap, right? So CHC love me because they've made them spend a fortune, but we're keeping her out of hospital, so we're saving money. So it's really trying to weigh up what's the right thing. Now, the lung volume recruitment bag was great, but it was really hard for carers to treat. I was quite happy doing it. I'd got training from the respiratory physios on the hospital where I used to work, and I said, can you show me? It wasn't a thing back in when I was on the wards. You basically deliver deep breaths, and it just helps with that inspiratory phase of the cough. So you're giving a deep breath in with the active cycle of breathing, and then she was able to cough a bit more effectively. Unfortunately, since COVID, all the parts were used up for using on the ventilators, and then the price went up, and now they just don't make the whole set. So if you wanted to get one, you have to buy all the different components and make a set up, and it's just, the thought of doing it is just so time consuming. And we were getting to the point where it just wasn't quite as effective as what we wanted. So we explored the cough assist. After much resistance from me, I was cynical about it. And everyone said, I've been to the reverse Rett, and Professor Sharma, you really must speak to him, has talked about the cough assist. And I was like, oh, okay. Thinking I've got to ask CHC for more things, and Claire's sort of ticking over okay. Did some research. Philips Respironics, who used to produce most of them in the UK, stopped supplying them. There was some issue. So we spent a year figuring that out. And then I found 2 on the market. So there's the Nippy Clearway by Breus, and there's S-Med Byways Cough Assist. And that's what I've gone for, because actually back in the day when I used to use it on ITU, it used to have a flip. switch, and you used to have to hold the mask on the patient, do their percussion and vibs, and flip the switch for inspiratory, expiratory. And it's all these pressures and things, and it was just really difficult. So I think my age was showing at this point. But I've discovered that the newer devices have an inspiratory flow where you can set it to really sensitive, and you pop the mask on, press play, and it delivers her breath when she breathes in. So it times it, and technology is awesome, it times it to her breath. So I don't have to worry about synchronising when I turn it on, turn it off. I just have to get the pressures right, and then I lock it, and then the care staff literally pop the mask on her face, press play, and it just works for her. And the rep said to me, I've never seen it work that well on anyone before, and it was very satisfying. So we had lots of lovely sputum. So it basically delivers a deep breath in, and you can set the pressures, because you're putting pressure in someone's lungs, you don't want to cause trauma. And then it flips into negative pressure, so it's that in-breath and then the out-breath. So we're working through the phases. You can do all sorts of settings about pausing, the length of the breath, the flow of the air. There's all sorts of things we can play around with there to really sort of help with that individual. But it's just really effective. And feedback from people with things like motor neurone disease is that it just feels so lovely to take a deep breath and have a cough. So we've got some like real patient feedback as well. So I am whizzing through this, sorry, I'm just going as fast as I can. Oh, I'm going over, sorry. I use a traffic light system, the RAG rating, and Claire's got a respiratory action plan, and I've written green, what's normal for her. She normally has NEBS, she normally has her like Foster inhaler, blah, 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 what her normal breathing is, what her normal respiratory rate is, her normal oxygen, how I take her oxygen, because it's only her right big toe that you can get a decent SATS reading on. There's a reason for that, but I don't go into that. And then when does it tip into amber? When do you need to start thinking, do I get some help? And so popping those things in there. And then red is, urgent medical intervention. And I think basically as a parent or a caregiver, if in doubt, call for help. I don't think you're ever going to get, or if you are, then they're wrong, get into trouble for escalating. You can always cancel ambulances and things when people improve. It's just having that extra support there to make a decision. And then some questions for your team. So thinking about with physio, what are the best positions? What's a simple routine? We don't want to be, you guys have got enough to do. We don't want to be adding in more labour intensive work to do. If you're getting frequent chest infections, that needs to be made sure that happens on your annual health review with the GP, that you log how many infections, how long did they last, what sputum was coming up, those sorts of things. Things like regular vaccines, those sorts of things. I'm extrapolating from COPD guidelines, but I don't see why it can't be used in this population. Things like regular vaccinations and general lung health. And then asking yourself, are we moving enough? Are we hydrating well enough? What are the warning signs? But you're the expert on your child, and it's really important that we listen to that. So there's a little health checklist I mentioned. The biggest things that Claire's taught me is how important prevention is for prophylactic input, and that often we have to fight for it because it's not been researched and there's not evidence to support it, but we can extrapolate from other data. That parents know best. Movement is respiratory medicine, or motion is lotion. Positioning, ask early, small changes, and it's about quality, not quantity as well. So thank you very much. Any questions?